Well, welcome and good evening to everybody. Thank you so much for coming to this presentation. It's 6:30, so I'd like to start right on time. I've been practicing urology in this community now for over 30 years, and every once in a while, something that's a game changer happens. For example, in 1985, the machines that disintegrated kidney stones became available. Up until then, we had to do open operations to take out kidney stones. That was a real game changer in the way we practice urology. Tonight, we're going to talk about a new technology that I feel is a game changer for the detection of prostate cancer. It's a completely new paradigm that completely changes the way that we're going to practice urology in the future. Just some little notes. You have these little question forms. If you have any questions, you can write them down. We'll have a short question and answer session at the end if you have any burning questions. I'm going to talk a little bit about why this new technology was developed and where it fits in. Then we have Dr. Fiske, who's one of our radiologists at NorCal Urology, who reads and interprets these pictures, and he's going to show you some of the pictures, some of these very great advancements that they've made. And we have Jamie Rembert in the back, who's a radiation oncologist. He'll be here to answer any questions in that field if you have any. I also like to introduce Linda Adams. Where's Linda? She's way in the back. She's our incontinence nurse. If anybody here has issues with incontinence, you might want to just check with her. She is a wonderful, wonderful asset to our practice and a very, very great person to talk to. But why? So we're going to talk about this technique. It's called MRI-Ultrasound Fusion Guided Biopsy. Everybody knows what an MRI is, magnetic resonance imaging. Ultrasound is an imaging technique. So we're going to answer the question, why do these MRI ultrasound guided biopsies? First of all, prostate cancer is important. It's the second leading cause of cancer deaths in men. It's the commonest cancer in men, but death rate is second to lung cancer. Just a review of everybody's anatomy. I'm sure you're aware of this, but it's hard for me to point from here, but the bladder sits up here. The bladder stores urine and empties. That's its job. The prostate gland sits right underneath the bladder, and the urethra, like a river runs through it, runs right through the middle of the prostate. As men get older, the prostate gland enlarges with age. It's just part of the natural aging process. And an enlarged prostate can cause symptoms. We call that BPH. What are the symptoms of an enlarging prostate? Stream doesn't start right away, doesn't flow as fast, it may start and stop. You may have to go a second time because you couldn't empty the first time. The bladder reacts to this outflow obstruction by having to squeeze harder to empty. So men start to get more frequent urination, more urgent urination. They start getting up at night to go. Those are all symptoms of just the enlarging prostate with age. What is prostate cancer? That's different. These are cells that start to grow out of control. It usually starts as a very small little tumor in the prostate, and as time goes by, it gets bigger and bigger. It's dangerous if the cells leave the prostate and spread to other tissues. Then it becomes very dangerous. There are no early symptoms of prostate cancer. That little tiny growth in the prostate causes no symptoms. So in its early stages, this is when you want to catch it before it spreads, there are no symptoms at all. Most cancers, like colon cancer or lung cancer, they cause symptoms. You can have a cough, or you can have blood in your bowel movements. So you have a symptom and you go to the doctor and they evaluate it and they find out what you have. With prostate cancer in its curable stages, there are no symptoms. So we have to do screening tests to find it. In the days before the PSA blood test, bone pain was the commonest presenting symptom of prostate cancer. So early detection is important, and that's because if the cancer is detected while it's still confined to the prostate or the immediate region of the prostate, still potentially curable. Once the cancer cells spread elsewhere to the bones or to the regional glands, no longer curable. It's treatable, we can keep it under control for years, but not curable. So how do you know you've got early stage prostate cancer? In the days before the PSA blood test, all we had was the digital rectal exam. Every man here has had that famous digital rectal exam, not our favorite thing, but that's all we had. It discovered a whopping 10 to 20% of prostate cancers. The PSA blood test came out, that stands for prostate specific antigen. It's not prostate cancer specific, it's just prostate specific. It's a blood test. Most men have had a PSA blood test. Upper limit of normal is around 4. Sometimes we use a lower level if you're much younger. But it's now the commonest screening test for prostate cancer. If your PSA blood test is elevated, it means you might have it. It's not a definite thing. You might have it. 20% of men with prostate cancer have a perfectly normal PSA. So we still need to do the rectal exam and the PSA blood test. If either one of those tests is positive, we do a prostate biopsy. Has anybody here had a prostate biopsy? Yeah, just about everybody. So for those who haven't had a prostate biopsy, I'll explain it to you. The urologist puts an ultrasound probe shaped like my finger in the rectum. We image the prostate in fairly high resolution. In the olden days, that's the early 1990s, before we had the PSA blood test, a lot of these prostate cancers you could see very easily on ultrasound because they were so large. Now that we have essentially wiped that out with PSA screening and we're just seeing the new cases that pop up, usually the ultrasound picture of the prostate is quite normal looking. So when we image the prostate, we inject some Novocaine in the prostate to make it go numb. We then take 12, they're called systematic biopsies, just evenly spaced through the prostate, just 12 biopsies. When we do that and the PSA is between 4 and 10, about 30% of the time we find cancer. 70% of the time we don't. But that's what we've been doing for the past 25 years. Now, we have this MRI-Ultrasound Fusion Guided Biopsy, which we'll get to in a minute. Just going to go back a slide here. So this is a rectal exam. This is the urologist's finger right here, pushing through the wall of the rectum, and here's this bump in the prostate. The prostate itself should be soft like a sponge. I always picture just this fleshy part of your thumb. That's what the prostate feels like. Prostate cancer feels like your knuckle. So when we're checking the prostate, we want to see if we can feel a hard spot. The problem is, what if that bump was over here, or over here, over here? You can see why a rectal exam only discovers maybe 20% of cancers. They just happen to be in a location where we can feel it. If you have prostate cancer on the biopsy, the pathologist assigns it a score called a Gleason score. It's a measure of how biologically aggressive the cancer is. The scale basically goes from 6 to 10. 6s are the slowest growing type. They're the best type. They grow very slowly. They don't tend to get into the bloodstream and spread. Nowadays, we don't consider Gleason 6s life-threatening. And so we often just observe these. We don't even treat every Gleason 6 we see. Gleason 7s are more dangerous. Now the cells have mutated. they have cells that can get into the bloodstream and spread. 8, 9s, and 10s, much, much more dangerous. They do have cells that can spread early, so they have to be caught very early. Now, the problem with those systematic biopsies, when we just take 12 evenly spaced biopsies, you could miss something in between them, and will often just by accident catch one of the little slow-growing Gleason 6 cancers. So here's a picture of the problem with systematic biopsies. And these little streaks are the little biopsy needles that we use to take biopsies. And this is a typical pattern of how we biopsy. We just space them equally apart. Well, there can be a little cancer in between where we took it. It can be above where we took the biopsies. It may be in a completely different zone that we don't usually biopsy because most of the cancers are in this darker blue area. It can be farther to the side of what we biopsied. And we often, just by accident, pick up one of these little tiny Gleason 6 cancers that could have sat there for 20 years and never bothered the patient. And here a patient now has a diagnosis of prostate cancer when he's probably not going to die of it or progress to a point where he gets symptoms. So the advantages of MRI. The radiologists have been doing MRIs for years, and they thought they knew what prostate cancer looked like, and they tell us biopsy here and biopsy there, and it was really no better than just our systematic biopsies. In the past, I'd say 6 months, they have developed a very accurate way, number one, of telling us what prostate cancer looks like, and not only that, they can identify those Gleason 7s, 8s, and 9s, and 10s. So they can actually image the ones that we want to detect. And these little slow-growing, little tiny Gleason 6 cancers that we'd much rather not know are there, they can't see very well on ultrasound, so they don't tell us to biopsy those spots. Now the other problem was, okay, let's say they see it over here in the prostate, but I don't know exactly where that is in 3 dimensions. For them to try and do a biopsy in an MRI machine is very cumbersome. Has anyone here had an MRI where you go through that narrow tube? And so how can they even get between your legs to put a probe in there? It can't be metallic because the MRI uses magnets, so there can be no iron or ferrous material of any kind. And then it's not a real-time image. They say they see it there, and then they have to put a needle kind of somewhere near it and then take another scan, and is it in that spot or not? You can see that biopsying in an MRI machine is practically impossible. So very recently, the technology has been developed where the radiologist can transfer that MRI image to my real-time live ultrasound machine. We can fuse my ultrasound image to the MRI machine in 3D. And I have a 3D image of the prostate. The radiologist puts a little target that he thinks is the spot where we need to biopsy, and we can biopsy that exact target real time in 3D. So when Dr. Fiske does an MRI, he assigns it a PIRAD score. It's called PIRAD stands for Prostate Imaging Recording and Data System. That's why we call it PIRAD. If they see a 1 or 2, and it's a scale from 1 to 5, PIRAD's 1s and 2 lesions when we've biopsied 0 prostate cancers on biopsy. That's 60% of patients. So if someone comes to me with a elevated PSA, I send them for an MRI and they have a PIRAD's 1 or 2. They don't even need a biopsy. We just say, see you again next year and we'll see if something's changed. 60% of patients we've eliminated, quote, unnecessary biopsies. If they see a 3 to 5, you can see 3s have about 8% positive biopsy rates. 4s and 5s have about a 70% positive biopsy rate. So if they can see something there, I don't have to do just those blind patterned biopsies. I can target the spot that they are seeing. And so our biopsy positivity rate has gone from 30% to 70%. So this just summarizes what I said. They transfer the MRI images onto our real-time ultrasound machines. In 3D, we see the target and we can target the spots that they're seeing. This is what a workstation looks like in our office. We have the ultrasound image up here, the MRI image up here, and a 3D model of the prostate with the target over here. And what we do real time is we can circle the ultrasound image. So this is a live image of the prostate, and this is his MRI image. And I don't know if you can see it, but there's a little dark spot right where this circle is. That's what prostate cancer looks like in that zone. And the radiologist has put a target there for me to biopsy. And if you look at the ultrasound, it doesn't look any different at all. You can't see that spot at all on ultrasound when you can see it so clearly on the MRI. And we can put this little dotted line right where we want to take the biopsy. And this image, let me go back, sorry. So in this image, this little streak is the needle where we took the biopsy, and we can see we hit that target exactly. And this shows in 3D exactly where it was, and we can roll that 3D model around. It is absolutely amazing. And after we take the biopsy, review our results, you can see that we were able to definitely target this lesion and these other 2 lesions over here. So it's a targeted biopsy, fewer biopsies per patient, more accurate biopsies per patient. So the results. We have a lot of men who've had previous negative biopsies. We bring them back to our office. Some of them have had 2, 3, 4 previous negative biopsies, but we're still suspicious. When we biopsied these patients, 64% we found the cancer. And in men who have not had a previous biopsy, it's 90%. Fewer biopsies, targeted biopsies. So I just want to summarize, because I don't want to bore you, but the hard indications for a prostate MRI now are men who've had a previous negative biopsy, who have a rising PSA, or they have an abnormal DRE, that's digital rectal exam. We can feel a bump, but we've had negative biopsies in the past. A lot of our patients with those Gleason 6s, we're just watching because we think they have this indolent form of cancer. We do an MRI now. If they see something that looks like a 7, 8, or 9, we can target that spot and say, no, you don't have that indolent type, you have the more aggressive type, you need treatment. So all of our patients on, quote, active surveillance, we're sending for MRIs to look for something that we missed on those systematic biopsies. And I think that the likely paradigm for the future is going to be if you have an elevated PSA or an abnormal digital rectal exam, your next step is going to be an MRI and not a biopsy, unless it's pretty obvious that it's advanced cancer. We don't absolutely need to do an MRI. But if standard patient, elevated PSA blood test or abnormal rectal exam gets an MRI first, 60% won't need a biopsy. There'll be those PIRADS 1s or 2s. We'll just see you again in 6 months or a year and recheck you. In those that do have a higher PIRAD score, we're going to biopsy them and find the cancer, usually on the first go around. So that's my prediction for the future. So that concludes my remarks on why I think this is game-changing technology for the way I practice urology. Now I'd like to introduce Dr. Charles Fiske, who's from NorCal Imaging, who's been become an expert at performing and reading these images and putting those little targets for me to aim at. And he's going to show you. We'll have questions, I think, at the end, so just write them down and hold them. That way we can get through the program. I thank you for your attention. We also have Dr. Jamie Rembert, who's a radiation oncologist, who will be on the panel in case you have any questions for him at the end as well. So, Dr. Fiske.
So thank you all for coming this evening and allowing us to share this really very interesting development in both diagnostic imaging as well as the urologic diagnosis and treatment of prostate cancer. My name is Chuck Fiske. I'm a diagnostic radiologist. I've been in practice in Walnut Creek for over 20 years. I have an office right over by John Muir Hospital. I have to say that in the number of years that I've been doing diagnostic imaging, which dates back quite a while, when I graduated from medical school in '76, we were just beginning to use CT scans at that time. And we've gone through a number of iterations of different imaging modalities since then with a lot of exciting developments. There was first CT, which allowed us for the first time to really see inside somebody's head, see what was going on without doing operations inside the abdomen. Then came along MRI, which allowed us to really revolutionize the way we look at neurologic disease and musculoskeletal disease. PET-CT came along, which changed completely the way we look at staging and diagnosing cancer, because for the first time we actually had physiologic information. We didn't just have anatomic information. And then came along breast MRI, which really revolutionized the way that we understand, diagnose, and treat breast cancer. This, of all of the ones I've done, is the most exciting development because it absolutely changes, as Dr. Taylor was indicating, for the first time, the way that we can more accurately diagnose prostate cancer and avoid a lot of over-diagnosis and over-treatment of prostate cancer. So I'm going to talk to you a little bit about some of the things that Dr. Taylor's already spoken about. There'll be a little bit of review there, but then I'm going to focus more on the imaging part, because the imaging part is really the part that has allowed us to move from just a screening PSA test, which he spoke about, to a blind biopsy, which only finds a cancer in about 60% of the time. So this is a development which really allows us for the first time to more accurately diagnose prostate cancer. Now, we're really fortunate in Walnut Creek because this is something that's only been developed in the last 2 or 3 years. And we're the first center outside of University of California in San Francisco to be doing this test. We've been doing it for about 4 months now, and like I say, it's really been excellent in allowing us to more accurately diagnose and localize these tumors. And I think it's going to change, as it already has, obviously, the way we approach this disease. So let's talk a little bit about what prostate cancer is. I know that Dr. Taylor's already mentioned some of this, but it's the second most common cancer in American men, second only to skin cancer. So it's really the most significant cancer that men deal with. It's the second leading cause of death in males, the first being lung cancer. 1 in 6 men will be diagnosed with prostate cancer during their lifetime. So it's a significant problem, and it's, if caught early, in the early stages and treated properly, there's a 94% survival rate at 15 years. So that's pretty significant. So if there's some way that we can impact that and get all the patients that we see into the level of diagnosing them early stage, then it's got a really curable, a really high cure rate. So that's the goal here. Well, the diagnosis, as Dr. Taylor had already indicated, has had limited success in the past. And the best indicator that we have is an elevated PSA, because the elevated PSA is an indicator, unfortunately, of a lot of different conditions of the prostate, but it's the best one that we have for really telling us, is there something that's creating this antigen that we're detecting that we need to be concerned about? The best way in approaching the elevated PSA in the past has been the trust biopsy, which is a transrectal ultrasound guided biopsy that Dr. Taylor was talking about. Unfortunately, as he indicated, the trust biopsy is both inaccurate and misleading. 40% of the time, the trust biopsy completely misses the significant cancer, and the technical issues that Dr. Taylor already reviewed are the main reasons for that. 40% of the time it finds insignificant cancer, and I know that's kind of an oxymoron because cancer is cancer, but insignificant in to the extent that it doesn't really need to be treated. And 40% miss the most aggressive portion of the cancer, so even if the biopsy comes back positive, 40% of the time it actually has missed the most aggressive part. So what's needed? Well, what's needed is what MRI provides. And that's a test which will accurately detect prostate cancer. You want to test that if prostate cancer is there, you're going to know it's there. You also want a test that shows that if prostate cancer isn't there, you can be confident, and that's called the negative predictive value. So prostate MRI has a negative predictive value in the range of 95%. So if you have an elevated PSA and your prostate MRI comes back normal or insignificant cancer, you can be 95% assured that you don't have prostate cancer. That's a significant improvement. In the past, we used to just sit on elevated PSAs and you would sit and wonder, okay, so when's my PSA going to go up and when is my prostate cancer finally going to declare itself to the point where we actually can biopsy it and make a diagnosis. Now with this test, we can be relatively sure that if you don't have the abnormal MRI, you're not going to have prostate cancer. We also want a test that's going to differentiate the high-grade cancers from the low-grade cancers so that we can move into the realm of what we call active surveillance, which is just watching these cancers rather than aggressively pursuing them, treating them, repeated biopsies, all of the interventions that are fraught with complications. And then we also want a test that's going to provide accurate staging. And staging is once you have diagnosed a cancer, what is the degree of it? Is it spread beyond the capsule of the prostate to involve surrounding structures, lymph nodes, distant metastases, all of the things that greatly influence and change the treatment. So multi-parametric MRI is actually not just an anatomic study. It's not just looking at the anatomy, but it's also a functional study, which means it measures the physiology of the tissue that you're taking a look at. The very fundamental portion of it is the actual anatomic information. What does the prostate look like? Where are the different parts of the gland? What's the capsule look like? What do the surrounding structures look like? But there's a very special and specific sequences that MRI has developed that I don't purport to even have the foggiest idea how they come up with these things, but the brilliant physicists that design these machines are able to come up with these sequences that help us differentiate different types of tissue. And one of the things that happens when you get a cancer is the cancer becomes very fibrotic and very sclerotic, and it excludes water from the surrounding. And water is what we image with MRI. MRI basically is a map of water in the body. And if you have a very fibrous area, it excludes the water, and it restricts the way that the water moves around when it's bounced with these magnetic and radio frequency waves. So the cancer itself actually shows different intensity depending on the sequences you use. And then the final thing we do is we give a contrast injection, and contrast fortunately works in our favor because most cancers are hypervascular. They tend to light up. The cancers have the ability to do what's called neovascularization, which they develop their own vascular supply and they become very, very hyperemic. And when you give contrast, they really light up. So you combine all these different physiologic information with the anatomic information, and you have what's called multi-parametric MRI. It allows us to use all these different sequence information to really go beyond just the anatomic diagnosis. And we always throw in a computer in there because you got to have the computers to help you really, understand what you're looking at. And it gives you the helps give you the tissue diagnosis based on a whole bunch of parameters, which includes the degree of contrast enhancement, the degree of how much water is in there, or how much water is not in there. They're a very complex set of algorithms and parameters that help us come up with these multi-parametric measurements. Now, the essential elements are, it has to be a high field magnet, which is Tesla as a measurement of the magnetic field strength. It has to be at least a 3 Tesla magnet. Gives you high resolution. It's able to get the imaging done quickly because you want to do it without any motion. It also gives you higher resolution because the strong magnetic field allows you to get a much, much higher signal back from the tissue. It's a relatively short exam. It's between 45 minutes and 1 hour. It's just a matter of lying on your back. There's no rectal coil, so it's not uncomfortable. It does require some IV contrast, which helps us with the multi-parametric portion of it. So here's what a prostate looks like. Now I'll have to orient you here. This is a 60-year-old male with benign prostatic hypertrophy, which is a fancy way of saying that he's got a big prostate. And this is looking at him from the front. So if you, sorry, pushed the wrong button there. This is the right hip, this is the left hip. This white structure here is the urinary bladder. This is the prostate. The prostate sits right in the middle underneath it. And all of these little white and dark areas are the hyperplastic nodules that form benign prostatic hypertrophy. So this is not atypical for a 60-year-old male, maybe a little bit bigger than most, but I took this example just because it's real easy to show what the prostate looks like. If we then cut this in half, in other words, if we take a slice right through here, like you're slicing a loaf of bread, we get this image. And this is what the image looks, or the prostate looks like in cross-section. And we again have these hyperplastic nodules that are sitting in the middle of the prostate, and then what we call the peripheral zone, which sits around here. The rectum is back here. This is the patient's right side. This is the patient's left side. So this is sort of the basic information that we deal with. And this is just the 2-dimensional image. And it gives us not really a lot of physiologic information, just basically gives us the anatomy. And we can see that all of these little nodules in there are actually all benign nodules. They don't end up being anything that's worrisome or looks like cancer. There are no masses that are sitting back in what's called the peripheral zone, which is this white area here, which is actually where most of the prostate cancer comes from. So let's contrast that with somebody that has a high-grade Gleason 7 cancer. Now this is the image that I showed you before, sort of with the hip on the right side over here and the left side over here. This is the prostate gland here, and it's obviously because the arrows help you, direct your vision to where this cancer sits. I mean, this is not rocket science. I mean, it's pretty straightforward, and after a while, once you figure out some of the nuances of it, you can sort of figure out, okay, that doesn't belong there. That's different than what it should be. It's different from the rest of the gland. And then you combine that, I'll actually show you the cross-section. Here's what it looks like on the side. This doesn't show quite as well as the other, but you can see that this dark area over here is quite a bit different than its contralateral side over here. So you combine that with the physiologic information, and here's a contrast-enhanced image of that, and you can see that the computer helps you out here because it shows you where the red dot is, and that shows you that that's the area that's concerning, because not only is it dark on the anatomic image, but you now have physiologic information that tells you that it's hypervascular. And then the final piece of information that you get is what's called the restricted diffusion, and without going into a lot of chemistry, this just shows that it's very, very fibrotic. There's not a lot of water in there, and that's what happens when you have these cancers infiltrate the normal tissue. It excludes the water. So these 3 pieces of parametric information help combine and allow us to say, okay, this is a cancer. Now we can do some additional images, measurements on this that I won't go into detail, but the additional images allow us to stratify the risk in terms of the aggressiveness of this tumor, and that's where we're able to help the urologist by saying, okay, this is one that's really worrisome because it has all these features that make it concerning to us. It's not a low-grade cancer. This is a high-grade cancer, it's a Gleason 7. Okay, so here's just a contrast as a 55-year-old with a mildly elevated PSA. And in this particular case, he has a little tiny, it's only a 5 millimeter area of diminished signal intensity within the, whoops, sorry about that, within the peripheral zone here. And this ends up being a low-grade cancer. And how can we be sure that this is low-grade cancer? Well, part of it is both the size and location of it, but also the physiologic information that we get from it. Again, the multiparametric portion of it, which shows us that the what we call the restricted diffusion is much less than the previous one. That signal is not as great, so that we can downgrade that lesion into a category of one that's a low-grade cancer. And this is the one that we can just watch. We can use active surveillance with. We don't have to go in and biopsy it. We don't have to be real aggressive with it. This is the one where you can take the patient with the elevated PSA and you can say, okay, he has a low-grade tumor, but we don't need to worry about it. We can just watch it. If the PSA starts to rapidly rise, then we can go back and look at it again. But for the time being, hands off, just leave it alone. So the second part of what MRI does is it allows us to target the images, and I won't spend a lot of time on this because Dr. Taylor reviewed this already, but the computer targeting of the images for the biopsy allows us to not only identify the suspicious lesions, but it allows us to target them. Basically, we can locate them, circle them. The computer technology is incredible. And it's amazing what the computer has done in allowing us to take this physiologic information, translate it into the digital information that can then be used by the urologist to fuse with the MRI images on their ultrasound to really target these things. They have a challenge to really make things sort of line up properly, but at least they're not shooting in the dark, and they have a much higher chance of actually finding the right lesion. It takes a little more time and they have to be a little more careful, but in the final analysis, the accuracy is much, much greater. So here's what, just to walk you through what it looks like with a high-grade cancer in a 75-year-old male. We can see there's actually two areas in here that are worrisome. There's this one area right here, that's this dark area on the T2 weighted image in the middle of the transition zone, and then there's another one back here in the peripheral zone. Both of these are suspicious looking. So, and again, you do use the physiologic information. This is contrast enhancement. The red marks the target for you, lets you know that yes, what you're seeing on your T2 weighted image is something that you need to be concerned about from the standpoint of the physiologic information. So you draw a target around it. And again, this is like amazing technology. It's almost like doing a video game. I have a great job. I mean, I just get to look at pictures all day and play video games. But these are really fantastic because what it allows you to do is target these things very precisely and come up with an image that then the urologist can use when they do their fusion imaging. And here's a sample of what the images look like, as Dr. Taylor showed you earlier. This is the ultrasound image with the fused image, and then this is what the targeted prostate, this halo here shows the contour of the prostate, and these little circles in there show the target, and you can see that Dr. Taylor has successfully skewered these, and in fact this came back with a high-grade cancer, just as the multiparametric MRI predicted. And in fact, it's so high that unfortunately this poor patient unfortunately has metastases, and we can also diagnose the extent of disease, staging it with the MRI. And here, you'll have to take my word for it, but these are enlarged lymph nodes in the groin that have spread already from this patient with prostate cancer. So who's a candidate? Well, as Dr. Taylor indicated before, it's basically the patient that has a persistently elevated PSA. PSA is now a great screening study. For a while it wasn't. And in fact, it led a lot of professional organizations to recommend against using PSA as a screening test because the results of the trust biopsies were so poor that it wasn't really regarded as a good screening study. Now PSA is actually a good screening study, particularly those patients who have either an elevated PSA or a rapidly rising PSA, one that goes from a relatively low level to all of a sudden starting to take off. Those patients that have had negative trust biopsies with an elevated PSA, Dr. Taylor showed the excellent results that have occurred as this. In fact, there was an article in this week's JAMA, which is the Journal of American Medical Association, coming out that's just confirmed the utility of the fused MRI-Ultrasound biopsies as being significantly improved in terms of the diagnosis of prostate cancer. You can stage the cancer, in other words, the extent and location of it, find nodes that are positive or metastases that have occurred within the pelvis or the spine. And really, as important, this is the thing that is really going to change it in many ways, surveillance of low-grade cancers. Instead of jumping in and being aggressive with a low-grade cancer, we can step back and say, okay, now we have a test where we can actively watch this and make sure that it's not getting out of control and avoid the extra biopsies, avoid the aggressive therapies with all the complications and side effects, the incontinence, the sexual dysfunction, everything that goes along with surgeries for really low-grade cancers. So the goals, I think, are being met, and we're really excited about seeing where this goes in the future, because I'm sure that as it becomes more widely known about the utility of this technique, that it's going to be something that really changes completely the way we approach prostate cancer, because now we can reliably detect and we can localize the cancers, where before we could detect them but we couldn't reliably localize them. We can avoid the unnecessary biopsies in a significant number of patients. Most importantly, we can ensure the absence of significant disease, that negative predictive value. If you've got a normal MRI, less than a 5% chance that you got prostate cancer. And it allows for the active surveillance of the low-grade cancers so we can avoid those unnecessary biopsies in the future.